We've got Amy Mooney joining us today. She's an occupational therapist coming up to us from Chicago, where she has her own physical therapy clinic called OT for Me. So go ahead, take it away, Amy.
Thank you so much. Let me share my screen and start. So yes, hello, and thank you for inviting me to this. I am really excited to be part of your part of the world. My name again, yes, is Amy Mooney. I'm an occupational therapist. I specialize in ME, CFS, long COVID, and other chronic conditions associated with post-exertional malaise. So I provide telehealth services through my private practice, which is an occupational therapy practice titled OT for the number 4 ME. And I serve as a clinical and education affiliate with the Bateman Horn Center out of Salt Lake City, Utah. So more than 12 years ago, I stepped away from my more traditional OT practice to care for a loved one whose illness had not been diagnosed yet. It took years before she received a diagnosis of ME/CFS. And during that time, she was often treated using rehabilitative approaches that was based on deconditioning, pain, and fatigue models that did not reflect her lived experience. And what I was witnessing and the care being provided often felt mismatched. The recommendations made sense within traditional rehab frameworks, yet they frequently led to the worsening of symptoms rather than improvements. And I remember thinking, if I'm observing this illness every day and still struggling to understand what happens, how can we expect a broader medical community to fully recognize a condition that was so often misunderstood? So over time, I realized that there was a missing part. I wasn't seeing post-exertional malaise. And once I began to understand that as an OT and a caregiver, I started to see the distinct multi-system response to exertion rather than simply fatigue or exercise intolerance. And then everything seemed to change. It changed how I viewed the illness, how I approached rehab, how I cared for my loved one, and ultimately how I support patients today. So my hope is that by the end of this session, you will be better equipped to recognizing post-exertional malaise and understand its impact on function and identify strategies that can help support patients you serve. Let me see. I have nothing to disclose. And again, thank you so much for allowing me to be here. We're going to dig into the nitty-gritty details of post-exertional malaise, or PEM, because how we understand it directly shapes how we treat it. PEM is often talked about in the context of long COVID or ME/CFS, but it frequently generically is grouped in with other symptoms like brain fog, fatigue, nausea, or general pain. And today we're going to take a step back and reframe that, looking at post-exertional malaise as the central feature that should guide how we approach care. Here are the learning objectives. You'll be able to hopefully differentiate PEM from fatigue and exertion intolerance, recognize how it presents in clinical practice, and understand the related diagnostic terminology, and also offer some coding so that you can use some documentation a little bit more accurately. You'll be able to be introduced to clinical strategies that can help hopefully support your individualized experience with PEM, including symptom pattern recognition, screening approaches, key concepts from my Pacing for PEM framework. For simplicity, throughout this presentation, I will refer to post-exertional malaise as PEM and myalgic encephalomyelitis, chronic fatigue syndrome as ME. This slide is adapted from a diagram developed from my colleague at Bateman Horn Center, Dr. Melanie Hoppers, who I saw that she's going to be presenting in a couple weeks, I think the end of July. So it highlights the important distinction that long COVID is not synonymous with ME. However, a significant subset of individuals with long COVID do meet the criteria of ME, where post-exertional malaise, or PEM, is the hallmark feature. PEM is not a single symptom that can be isolated or measured in the body system. Rather, it is a clinical phenomenon, a characteristic whole body response pattern that occurs following exertion. This abnormal response to activity is the defining feature of ME and should guide both our diagnostic approach and our treatment strategies. So recognizing whether PEM is present is essential, as it directly shapes appropriate clinical care and treatment. This same distinction is also critical when we look at research. Many studies do not clearly separate participants who experience PEM from those who do not, resulting in mixed population or pools or subject pools. When these groups are combined, the true severity and impact of PEM becomes diluted in the findings. And as a result, treatments may appear broadly effective in one group, but may in reality be very ineffective and even harmful for individuals, especially those with PEM. So the through line of today's session is this. If we do not accurately identify PEM, we cannot diagnose it correctly, treat it appropriately, or fully understand the disease in a way that improves patients' quality of life. Screening for PEM must happen at the very first point of contact, both clinically and in research, so that we are able to ensure that we are truly identifying and addressing the needs of this population. So this chart is from Open Medicine Foundation that summarizes the 5 major diagnostic criteria of ME that began starting in 1988. Historically, these criteria focused on fatigue, which led to that mixed subject pool and poorly defined patient groups. As our understanding of the disease has evolved, diagnostic frameworks have also shifted to recognize that PEM is a required feature, improving both identification and clinical care as we progress. This progression is important because we are now seeing similar challenges in how those patients with long COVID are being defined. Without clearly identifying PEM, we risk repeating the same pattern of mixing the population and providing not as effective care. Post-exertional malaise, or PEM, is defined as a disproportionate multi-system response triggered by exertion across multiple domains in both immediate and delayed symptom worsening. And this is from the NIH and also Bateman-Horn clinical guidelines. I've adapted it a little bit better, I think, because I don't necessarily see the definition that way. I see it in pillars. And what I've tried to describe are these 4 pillars of PEM. The first being that disproportionate response to even small stressors. The second being that multi-system response that affects body systems. Then exertion domains. It's not just physical. Triggers can come from any kind of stressor, cognitive, emotional, sensory, orthostatic demands, weather, chemical, any kind of stressors that belongs in a body reaction is going to cause an effect on the body. And then finally, that distinct symptom time course. Symptoms that may appear immediately kind of change and morph into something else, a whole nother beast. And that is often found delayed 12, 48, 72 hours later. People with PEM often describe it as a crash, a relapse, or a collapse. It is a multi-system response that's commonly likened to feeling as if you've had a flu or run a marathon. with a hangover, and then at the same time getting hit by a bus. Others say it feels like they are constantly being poisoned or they are being weighed down in cement. Unlike ordinary fatigue, PEM does not reliably resolve or improve with rest. And pushing through exertion can worsen disability rather than build endurance or health. In the next few slides, I want to clarify a few terms. PEM is not fatigue, and it is not chronic fatigue. Fatigue is that normal body experience. We often, in a healthy body, feel it as a response to exertion of lack of sleep, working a long day, and it usually resolves with rest. Chronic fatigue can occur in many conditions. Many diseases have chronic fatigue, and it may not be fully resolved with rest, but it is not the same reflected pattern as we see in ME. Chronic fatigue syndrome was introduced by the CDC after an outbreak in Klein Village, Nevada in 1988. It does not reflect the complexity of the disease. And by emphasizing fatigue in this name, it minimizes the multi-system condition that has contributed to this misunderstanding and stigmatization that patients feel. PEM is what defines and distinguishes ME as this multi-system disease. It is not just a symptom, but it is the hallmark response that reveals the complexity, severity, and systemic nature of the condition. Recognizing this distinction is essential in understanding illness and providing that appropriate care. Having discussed PEM, I want to compare fatigue and exertion intolerance. Fatigue is that feeling of being tired, drained, low energy. It's a common symptom experienced most often in the general population. Rest usually helps, and for some individuals, actual light activity may increase and improve alertness and energy levels, so exercise may help. Exertion intolerance is different. Symptoms occur during activity or shortly thereafter, and while rest may help somewhat, the activity tolerance is often unpredictable day to day. PEM is different from both. It represents a disproportionate response to a stressor with symptoms occurring across multiple body systems. Importantly, PEM can be triggered by those many types of exertion, those exertion domains. And the other's defining feature is that time course that I spoke about, with symptoms occurring immediate with activity and also delayed after the activity and post-recovery. While these symptoms can overlap, recognizing the differences help us identify PEM and choose the most appropriate management strategies. And then a couple other terms I want to cover here. PEM, PENE, and PESE. I've already discussed PEM. So on this slide, I want to focus on how these terms relate to each other. PENE, or post-exertion neuroimmune exhaustion, is a term used in the 2011 International Consensus Criteria, that ICC. That's one of the columns in that slide showing diagnostic criteria. They picked up on PENE in that particular criteria. While this terminology differs, PEN, PENE, and PEM are describing essentially the same core phenomenon, but PENE places greater emphasis on the neuroimmune and physiological dysfunction throughout as an underlying response. PESE, or post-exertional symptom exacerbation, is a broader umbrella term that simply describes worsening symptoms following exertion. It's commonly used with long COVID and rehab settings and does not necessarily imply the specific characteristics associated with PEM. So it may be, loss of smell, or it may be body pain. It may not have that those hallmark criteria that I've talked about with PEM. So a simple way to think about these terms is that PEM is that clinical phenomenon, the hallmark feature of ME. PENE is the ICC terminology that emphasizes that neuroimmune mechanism. And then PESE is that broader umbrella symptom description, just that symptoms worsen after any type of exertion. So the key takeaway is that PEM, PENE describe the core response, while PESE is the broader umbrella. Okay, going into some of the symptoms. This image is from the Mayo Clinic Proceedings article that illustrates the multi-system nature of PEM. Rather than a single symptom, PEM reflects that involvement across multiple systems that I have talked about. For example, immune symptoms like flu-like symptoms or sore throat, or neuromuscular, like feeling heavy, cemented muscle pains, or that autonomic dysfunction such as nausea, dizziness, or heart racing. Symptoms can vary and shift, including cognitive changes, pain, sleep disruption, and sensory sensitivities. What this highlights is that symptom expression is influenced by the type of body stressors or exertion. Physical, cognitive, emotional, or sensory each play different demands on the body and trigger the body to respond accordingly under stress. So when we think about PEM, we're not just talking about how much someone is doing, but what type of exertion the body is responding to. So the PEM screening questions, I want to identify what is PEM. I want you to have a tool that you can look at in your clinic. These questions, WorkWell Foundation has helped to identify whether someone is experiencing this disproportionate multi-system response to the exertion that defines post-exertional malaise, looking not only at the symptom burden, but it also about the delayed recovery over time. So this slide presents a simple screening approach that can hopefully guide some of your conversations. Number one, does the person experience severe fatigue along with at least 3 other symptoms, such as feeling unwell, feeling weak, poor or unrefreshed sleep, and having pain? And number 2, does it take a day or more to recover after physical exertion, cognitive, sensory, emotional, or orthostatic? These questions help the clinician move beyond simply identifying fatigue and instead begin recognizing the hallmark patterns of PEM, where exertion results in that, again, disproportionate symptom response and prolonged recovery. The delayed nature of symptom worsening is particularly important because patients may appear functioning during the activity, but they experience significant physiological consequences hours or even days later. And I want to highlight that word consequences because we're going to revisit that again and again. PEM does not have its own ICD-10 code. So we document underlying conditions. For ME, PEM is required. So it's kind of tagged along. If you see that if they've answered the screening questions and you can diagnose that they do have PEM, then they do qualify as having ME. And the code is G93.32. And for long COVID, we use U09.9 for a diagnostic code. While PEM is not required for a long COVID diagnosis, identifying it is essential as it directly informs clinical care. When appropriate, adding an ME diagnosis alongside a long COVID helps the care team. The OT, the PT, the speech who gets the referral now knows that they have to keep PEM as the central component of this patient's presentation and should guide clinical care. So we have often seen overlapping comorbid conditions such as dysautonomia, postural orthostatic tachycardia syndrome, POTS, hypermobility syndromes, mast cell activation. These comorbid conditions should also be coded and considered as part of that overall clinical picture. So what happens when we have the wrong tool for the job? If I hand you a wrench and ask you to drive in this screw, you could try, but you might even get some movement. It might work for a few turns, but the problem isn't your effort. It's that the tool doesn't match the job. So I think the same thing has happened historically with ME. Traditional rehab models are built on the assumption that the body adapts to activity and recovers afterwards. When a patient becomes deconditioned, we often expect that gradually increasing activity will improve function over time. But ME is defined as impaired recovery following exertion. The challenge is not simply reduced tolerance for activity. It is the abnormal physiological response that occurs after activity. When we apply rehabilitative models designed for adaptation and recovery to a condition characterized by impaired recovery, patients worsen rather than improve. This isn't about clinicians doing the rehabilitation incorrectly. It's about recognizing ME requires a different framework. Before we can choose the right intervention, we first have to understand the nature of the illness we are treating. If traditional rehabilitation may be the wrong tool for PEM, then the next question becomes, what should we be paying attention to instead? And in this slide represents the shift that occurred in my own clinical practice as a caregiver. This is what happened years and years ago when I said, this does not fit what I'm seeing at home. Traditionally, therapy has often focused on what we can directly observe and measure. We watch how a patient performs an activity, how far they can walk, how many repetitions they can complete, and perform daily tasks. These are what's visible as part of function, the tip of the iceberg. The challenge with PEM is that the most important information occurs after the appointment is over, the essence of the disease. A patient may appear successful during the therapy session, complete the activity, and even report feeling well enough. Yet hours later or the next day, they may experience a significant worsening of symptoms and a decline in functional capacity. That crash occurs at home, outside of the clinic, and is often witnessed by the patient and their family. In many ways, PEM is the portion of the iceberg that is beneath the water. If we only focus on what we can observe during treatment, we miss the very thing that is driving the disability, and this is the essence of the disease. The pacing for PEM framework turns that iceberg upside down. Rather than focusing exclusively on how an activity is performed, we focus on what happens between the activities. We look at recovery, symptom patterns, baseline stability, and how exertion impacts functional capacity over time. The question shifts from, can the patient do this activity today, to what will this activity cost the patient tomorrow, next week, and over the long term? What are the consequences? This changes the perspective fundamentally, and it fundamentally alters how we evaluate progress, prescribe activity, and support patients living with PEM. Patients are often told, pace. Pacing is what is advised, and it is usually, unfortunately, feels pretty vague, and it's overwhelming, and it feels very generic. It's like telling somebody with diabetes, just eat healthier. Pacing is more than that. It is a structured way of managing exertion over time. And this is where I consider that there are three pacing categories. General pacing, which is the pacing for individuals without significant health concerns. Therapeutic pacing is for individuals with an intact metabolism and conditions that do not involve PEM. And this often includes professionals giving the patients guidance, and the patients then can work on self-assessment and adjust activity levels with that structured care from a professional. Rest usually relieves symptoms and can then help return function to baseline. But for pacing for PEM, it's for those with an impaired metabolic functioning. This requires managing tasks, exertion, and recovery across time. Exertion before, during, and after the activity must be considered, making it a lifestyle approach. Rest alone does not resolve symptoms, and baseline functioning may remain reduced for days, weeks, or longer. So pacing for PEM, I tried to develop this treatment approach to address that hidden nature of PEM. Instead of pushing through, it emphasizes staying within the body's functional capacity to avoid crashes. It fosters stability through both preemptive and recuperative rest, while recognizing that even small stressors can accumulate and trigger significant symptom consequences. And this is the brief overview of my pacing for PEM activity and rest analysis. This is the framework that I try to use for my patients and just trying to put a little bit more structure in this plan. I share it not as a prescriptive model, but as a way to think about symptom assessment and functional impact. While treatment may include medications and other interventions, having a structured approach to PEM can support clinical decision-making and more individualized care. So at a high level of this framework, it includes 4 steps. First, identifying the symptom time course. We want to understand which symptom occurs most frequently, when they occur, and how they impact function, our functional performance, and the ability to rest and recover. Second, I look at analyzing the exertion stressors that are involved in the activity. This includes that physical, cognitive, social, emotional, sensory, orthostatic, those exertional loads, while the demands that contribute to the symptom worsening and triggering PEM. And third is making accommodations and modifications based on those identified symptom stressors, based on 2. The goal is to reduce unnecessary exertion load while preserving participation and meaningful activity. And then finally is developing that radical rest for PEM strategies and support kits. Rest becomes a therapeutic intervention that is intentionally matched to the patient's symptom presentation and used to support recovery, baseline stability, and functional capacity. I'm looking at what systems were involved in their stressors and their activity, and then specifically designing rest strategies so that those systems are supported. So together, these 4 steps provide a practical framework for understanding how activity and rest interact in patients experiencing PEM. Many people are familiar with the concept of energy envelope or even the spoon theory. These are helpful introductions to pacing, but in my practice of pacing, it's more dynamic than just managing a fixed amount of energy each day. The phone analogy helps explain capacity. Your body is a platform, and some days it may function like a newer iPhone 14 with plenty of battery life and a processing power that you need for that day. Other days you may feel like you have an iPhone 4 with very limited capacity. Capacities can change from day to day or even hour to hour. And when using a phone analogy, I encourage patients to ask, which platform do I have right now? What are the app demands that this type of activity is going to require? So think about activities are the apps, and some require very little power, while others demand much more processing capacity. And then I also want to use the analogy of the credit card to help kind of explain consequences. Your available capacity is your daily budget, and every activity unfortunately has a cost. If you stay within your budget, stability is more likely. If you exceed it, you may complete that activity today, but the bill, that APR, that bill with a whole lot of consequences is going to arrive later in the form of PEM. When using the credit card analogy, I encourage my patients to ask, what is the daily budget? And then what is that cost of exceeding my budget or my balance? The goal of pacing is not maximizing activity. It's not hitting that ceiling or hitting that credit card max. It's matching the activity demands to the available capacity and understanding the consequences of exceeding your limits. And one way I want to look at this, and I try to explain to my patients, is how to understand PEM is through the capacity bucket. The large bucket represents your overall functional capacity. Inside, there are different exertion domains that I've talked about that contribute to that total load. These are not separate energy sources. You have one energy source, but they have different ways of demanding exertion from that same system. A patient may tolerate one domain better than another. Maybe somebody does tolerate physical better than cognitive. They all contribute, though, to the same overload in the big bucket. This is why it's challenging for activities that you cannot exactly change activities. It does not necessarily reduce the exertion. A patient may switch from a physical task to a social task or a cognitive task, but yet they still they are still filling their bucket overall. As the bucket fills, symptoms often emerge as warning signals, and that system is approaching its limit. If demands continue to exceed capacity, the bucket overflows and the PEM crash will occur. So the goal of pacing is to identify which domains fill and at what rate, and then matching those demands with your available capacity. This, over time, can protect function and produce a more stable baseline. So on the previous slide, I looked at that overall capacity bucket, but this slide zooms in on individual exertion domains that contribute to that total load. So this is those nesting buckets. Each bucket represents a different type of exertion. The key questions are, how full is each bucket? Which bucket fills the fastest, and which symptoms appear as the bucket approaches its limits. Every patient has a unique pattern. One may struggle most with cognitive tasks, while another is more limited by social or sensory. Most activities fill multiple buckets at once. For example, grocery shopping. It involves physical activity, cognitive planning, sensory stimulation, social interactions, and orthostatic demands. You're upright. This helps explain why patients may appear inconsistent. They may have the capacity for one or two of those domains while the other is already exceeding or meeting the threshold. The goal of pacing, again, is to identify which bucket fills quickly, recognizing activities that place these demands across multiple domains, and then adjust the activity before symptoms escalate and PEM occurs. This is where accommodations and modifications kind of fit in. So one of the first steps in pacing is identifying the PEM symptom time course. from my cheat sheet that I showed you earlier. This understanding not only is which symptoms occur, but when do they occur? So as patients learn their symptom patterns, they begin to distinguish between what is uncomfortable and what is truly disabling. I often divide these symptoms into two categories, the immediate symptoms and delayed. That's what I consider the time course. Immediate symptoms are the doing too much signals. It's kind of that water level is going from the chest up to the nose. You're feeling a little bit overwhelmed. They are the warning signals that the bucket or that water level is rising, and the symptom is approaching its limit. The goal is to recognize these signals early and adjust activity before the symptoms escalate. The delayed symptoms are the consequences. They may occur hours or even a few days later after the activity, and often result in what the patients describe as the crash. For each patient, I want to understand what are the stop signals, when do the delayed symptoms begin, how long do they last, and then I want to track both the stop signals and those delayed consequences to help patients better understand their threshold, that ceiling, while making pacing decisions and reducing the likelihood of triggering PEM. And this is how I do it, is I go through worksheets like this. I use it to track the immediate and delayed symptoms, those stop signals. Patients begin to see how their stressors lead to symptom exacerbation and when they've exceeded their threshold, when they've gotten to the ceiling. A helpful prompt can be, what 3 symptoms show up most often when you've done too much? Physical, cognitive, social, emotional. We can extend this into a longer chart, but it's usually these 3 that I try to address first. It can be extremely hard first, but over time, patterns can emerge, making it easier to adjust pacing and plan activities more realistically. And after recognizing immediate symptoms, or those stop signals, I then start identifying delayed. What symptoms appear 12 hours or 48 hours later? These crashes are often the most disruptive because they're not necessarily, they're separated. They're not tagged onto the original stressor. And so these are consequences of exertion, but they don't seem as apparent. They don't seem as obvious. So it takes a lot of time to work through these with patients. For me, this is the piece of exertion stressor, the pacing for PEM part of the program that I feel that occupational therapy it has a tremendous impact with. This looks at quality of life for patients with PEM. It's one of our strengths because we have frames of references that can help analyze and organize activities and how they interact with the multiple body systems, and then use that information to create practical accommodations and modifications. So when we analyze exertion stressors, we look beyond activity itself and ask, what is the body actually experiencing in this task? So we consider factors such as time. So how long has this activity been performed? What time of day is it occurring? How much recovery is available before the next demand is on the body? Or sensory. What are the lights, the sounds, the touch, the smell, the taste, the internal body signals, that interoception and proprioception that is happening on a sensory base? Orthostatic demands, the effect of being upright, standing, walking, weight bearing, the result of heart rate and blood pressure changing in a vascular way. And then looking at what emotional demands an individual is facing, both positive and negative, what happy emotions and stressful emotions are interacting on a personal level. And then the environment. What is that temperature? Is it hot and steamy, or is it really cold? What are the changes? Is there a storm coming through? Is the barometric pressure changing? Is the wind affecting the body? What's the air quality, pollutants, mold, allergy triggers? I want to look at these as important points that an activity is part of. And this is rarely just a physical or a cognitive piece. Every activity is made up of multiple stressors that interact with one another and the systems of the body. By identifying the specific stressors and that contribute to the systems, we can help develop targeted accommodations and modifications that reduce the symptom burden, improve participation, and help patients maintain greater stability over time. And this, in turn, improves quality of life. Once we've identified these exertion stressors contributing to the symptoms, the next step is developing accommodations and modifications. So accommodations are those supports and strategies that help patients achieve their goals while reducing the workload on the system. The goal is not to eliminate meaningful work. The goal is to make those activities more manageable, less likely to contribute to symptom exacerbation and PEM. So the key question is, what can we reduce so that the workload is manageable without losing the core essence of the activity that matters to the individual? And when accommodations are matched to the patient's specific stressors, symptoms, they can significantly improve participation. And then, while looking at all the accommodations, we might be able to change everything in that person's environment and make the activity extremely energy conserving for the patient. It may come down to it that the actual goal needs to change. And this is where modification is put in place. It's actually adjusting and changing the criteria of the goal. This modification includes adjusting expectations, changing the criteria for success, or redefining what achievement looks like based on the individual's current capacity. And so in many ways, modification asks a different question. It's not, can I do this activity the way I used to do it, but what is the smallest version of this activity that still meets my goal? And I refer to this as the golden nugget. What is the golden nugget of this very meaningful activity in my day? And then the final step of the pacing for PEM framework is radical rest. Once we've understood that a patient's symptom pattern and exertion stressors, or even their accommodations and modifications, are being used, we need to add the rest strategy. And rest is not simply breaking, taking a break when symptoms appear. It's actually a proactive and intentional strategy that considers those past, present, and future exertion. And I divide these into two categories. Preemptive rest that occurs before the activity. It's preventative strategy designed to reduce symptom escalation and preserve baseline function. And then the recuperative rest, which occurs after the activity and after the baseline has exceeded a capacity. Its goal is to support recovery and return to baseline function. So together, these approaches help patients better manage their exertion over time. And for many patients with PEM, learning when and how to do rest is just as important as learning how to be active. So post-exertional malaise is not about avoiding activity at all. It's about matching activity demands to available capacity. By understanding symptom patterns, exertion stressors, accommodations, modification, and rest, strategic rest, we can help patients protect function, reduce crashes, and improve quality of life. Thank you.
All right, wonderful. Thank you
Thank
for
you.
that. So we did get a question early on asking about the difference between PEM and PENE, but I'm pretty sure you covered that in a slide
Yeah.
a little bit later on. Melinda,
Yeah.
did you get the answer you wanted, or do you have an additional question on that? And see if she comes back with anything. Nope, she says she's all good. Okay, does anybody else have any questions?
Yeah, I had several, but I was going to ask, does anyone else have questions regarding before I always like to ask questions. Sorry. So thank you, Amy, for a great presentation. So as you mentioned, so I think for Melinda, she was asking about PM and pen. So could you actually indeed have PEM, but not necessarily PENE and PESE. And I assume that these are underlining different mechanisms that affect either the cognitive and also perhaps mitochondrial, because you're talking about stressors with a mechanism of overexertion. So is there, is, I guess, there's difference in terminology. How important are these terminologies and why do we have them?
You know, I think on a clinical level, it is not necessary to be so hung up on the terminology. I wanted to express it because it shows up in literature, and I think patients are often using different terminology to hopefully describe the experience of how debilitating this condition is of PEM. PENE is looking at kind of what is the biological root of what is happening on a more more scientific level. Like, is the body having that neuroimmune response? So it's more put on the level of what a doctor might be looking at for medicine, using medicine to go after some neuroimmune treatments. But it has been used, but more in a clinical or in a research-based piece. And I think as clinicians, just using PEM to describe it captures the essence of what the patient experiences.
I think Candace was just mentioning how would PM PESE be screened. I think you were just mentioning just that. Perhaps it would be something to quickly, I guess PESE might be something more severe in an emergency setting.
PESE would be any kind of symptom. A patient might say, after I do an activity, I get a lot of brain fog, but it happens immediately. So that's their symptom. That it's worsening of symptom for that moment. It doesn't necessarily capture the delayed response. So I think it's just saying that you have a symptom after you do exertion. So it can be covered in, loss of smell, or it can be, for different qualities that do meet long COVID. Many people with Epstein-Barr that then went on to develop ME. They don't necessarily have the same types of symptoms as long COVID. So it's just showing that it kind of breaks down to a symptom is worse, but it doesn't necessarily have to stay under those four pillars that I tried to describe of you know of having a delayed time course, and maybe it's just only a cognitive exertion that triggers cognitive fog.
And Melinda was just mentioning, just following up about it translates to neuroimmunology and symptoms and triggers. Could you because of the triggers that occur, how would you treat PENEs? How would you kind of reduce the neuroinflammation symptoms? Do you have any tips as how to you could reduce those symptoms, the brain fog and issues like that?
As an occupational therapist, I'm not in the field of prescribing, but I think doing things that are going to be, keeping the body from going into an immune reaction. So keeping the stressor low and understanding where that ceiling is. But for a lot of patients that I have that are working with physicians, they're prescribing mast cell medications. They're doing things that are, really trying to keep that neuroinflammation at a lower targeted space. So it is kind of used in two different prongs of a pharmaceutical path
Yeah.
and non-pharmaceutical of kind of staying in a more closer to baseline, away from that ceiling, not exceeding the threshold as aggressively.
Yeah, Dr. Huber was mentioning about mast cell, and she's going to come back on to talk about mast cell activation. And I know a variety of individuals have been on the GLP-1s
Yeah.
and medications similar to try to help with that. So one of the big things was a lot of people have asked about supplements. What would you suggest as far as like diet and supplements? Do you have any things that you like to suggest?
I try. So the piece that I have to contribute is
Mm,
that people are so sensitive to change, and
mm,
and any kind of medicine or supplement or diet can be changed to the system.
oh,
So it needs to be very low, slow, over a time, because when a body is changing systemically, the body is chemically exerting. So I often, talk to my doctors and say, we're going to stabilize them first before certain medications are going to be trialed, because that medication is exertion. It's exertion on a
oh,
chemical level. So if we can keep them close to their baseline and very aggressively pacing, then they have space, they have capacity.
mm,
That water level is moved from their nose down to their chest, and they have capacity to tolerate supplements or medication or even a diet change,
yeah.
because the body needs time to process.
So you're saying that oftentimes like these changes in medications, it might not, sometimes as clinicians, we kind of push it, right? And so sometimes it might not lead to success because we just overexert the system with our medications and supplements.
Yeah,
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 right.
that is exactly it. That if a medication is not implemented at an appropriate time where the body has capacity, it will appear to fail or not be effective. When in reality, it may have been that the body was already quick to exceed its capacity,
Yeah,
and it needs to be tried at a different time. So it's finding that perfect window for slowly titrating to a therapeutic dose, giving the body time to rest, giving a new medication, right before a holiday is probably not a good time, because the body is going to want to do things and is already stressed and strained. Or, giving a medication when, somebody is just recovering from an illness is not the time. So knowing when that body actually try to say, if you do aggressive, 2 week window of aggressive pacing, then might be a better time to try a medication and talk, if I can work with the patient aggressively going through those worksheets and really kind of pulling apart their pacing strategies and saying, this is how close you can be to your baseline. You've moved, you're stable, your baseline is very, very stable. Let's talk to your doctor about trialing a medication at this period.
so go slow, but go steady. Okay.
Yep, yep,
Okay.
exactly.
I did just want to, what's your sense of a hyper mobility? You mentioned hypermobility spectrum.
Mhm.
Do you screen for people for all your clients on?
I I do.
Yeah.
And I work with my patients mainly telehealth. So I will just ask, how does your body feel? Do you feel like you are are you on, is your body moving in places that, is just unstable? And I do try to encourage them to use supports, use positioning strategies, use pillows and bolsters and keep their body as stable as they possibly can. Because when somebody is working to maintain their body in a a kind of a structured way, that's exertion. So if they can brace, then use the brace. And if they can then, go around their rooms, or they can, do some grooming activities wearing braces, then they're still using their body functionally. It's just those braces give them a little bit extra support so they're not exerting.
Okay. Melissa, do we have any more questions or?
Nope, it looks like we've got all of the questions that have been posted so far answered. So if nobody has anything else, we'll go ahead and wrap up for today. Thank you so much, Amy, for joining
Thank you.
us today. We really enjoyed having you. And for everybody else, make sure you complete your evaluation form so you can get your CME credit. And then if you're interested, our next session is on July 14th, and the topic that day will be viral persistence in long COVID. So everybody have a great rest of your day.